All right. Hello, everyone. Welcome to Caring and Living as Neighbors side event at the fourth International Conference on Small Island Developing States, brought to you by CLAN, Mates for Kids, Lehigh University, and the International Society for Neonatal Screening. My name is Katie Blomquist. I am a Master's of Public Health student at Lehigh University, a UN Youth Representative for CLAN, and the Mates for Kids Project Officer. And I will be co-hosting this event with Kate Armstrong, who is the president and co-founder of CLAN. So to get started, just some housekeeping. Please ensure you're muted if you're dialing in virtually. And lastly, this event will be recorded and posted with a report soon on the CLAN and Mates for Kids website, so stay tuned. We would like to acknowledge the lands that everyone is dialing in from virtually. We invite you to post the traditional lands you're on in the chat now. From Lehigh University in Bethlehem, Pennsylvania of the United States, I acknowledge I am presenting from the lands of the Lenape people, and I pay respect to elders past, present, and emerging. As CLAN is based in Australia, we acknowledge the traditional owners of country throughout Australia and recognize their continuing connection to land, waters, and community. We pay our respect to the First Nations people internationally and to their cultures and elders past, present, and future. This event is in partnership with the Lehigh University United Nations Youth Representative Program. The Lehigh Youth Representative Program started in 2008, where high-achieving Lehigh students are matched with UN-accredited NGOs. CLAN is one of the 9 NGOs and one of Lehigh's strongest partners. CLAN currently has 2 UN youth representatives, Nikki Pasterchik and myself, who advocate for CLAN at United Nations events such as this one. This program allows youth to have a voice in global matters and, in our case, treatment for children with non-communicable diseases. So this year's International Conference on Small Island Developing States focus is charting the course toward resilient prosperity. Our event's theme of newborn screening aligns with this theme. We believe scaling newborn screening will help children in small island developing nations enjoy the highest quality of life possible. The fourth interactive dialogue of SIDS4 is Investing in Human Capital, addressing health crises in SIDS and building the potential of youth in SIDS. This is integral to CLAN's mission, aiming to optimize health outcomes for children and their families coping with chronic conditions in resource-poor settings. Universal access to newborn screening is crucial to ensuring children with chronic health conditions that can be diagnosed at birth enjoy a quality of life comparable to their counterparts in more wealthy nations. This is CLAN's first presentation at the International Conference on Small Island Developing States. Our event's focus on newborn screening aligns with this theme, as it is a technology that contributes to fighting poverty by providing equal and early diagnosis of chronic conditions. In addition, CLAN's work with newborn screening supports efforts towards the Sustainable Development Goals of no poverty, good health and well-being, reduced inequalities, and partnerships for the goals. So newborn screening programs ideally support comprehensive approaches to the early diagnosis of congenital abnormalities and include physical examination of the body, hearing and vision checks, pulse oximetry, and heel prick blood spot testing. For those unfamiliar with the specifics of newborn blood spot screening, it is a heel prick method where blood samples are taken from a newborn and tested for multiple genetic, metabolic, endocrine, and long-term conditions. This is pivotal for children with chronic conditions, as early diagnosis and treatment within a few days of birth can prevent morbidity and mortality. Now I'd like to introduce you to CLAN. CLAN is short for Caring and Living as Neighbors and is an Australian non-governmental organization founded in 2004 by Kate Armstrong. CLAN is committed to equity for children living with chronic health conditions in resource-poor settings. CLAN's strategic framework for action focuses on multi-sectoral action on 5 pillars. Pillar 1 is affordable access to medication and equipment. Pillar 2 is education of the individuals, families, communities, health professionals, policymakers, and the international community. This is done through research and advocacy. Pillar 3 is the optimization of medical management, including primary, secondary, and tertiary prevention with a psychosocial focus. Pillar 4 is the encouragement of family support networks, and the final fifth pillar is reducing the financial burdens on families that result in poverty, helping people to become financially independent so they can provide the necessary health care for their children long term. CLAN is focused on promoting equitable access to newborn screening services for all children of the world, as it supports the early diagnosis and treatment of many chronic conditions of childhood that are associated with preventable morbidity and mortality. Special efforts are going to be needed to reach babies from resource-poor settings and families. I'd now like to introduce Dr. Kate Armstrong, founder of CLAN and co-chair of the Mates for Kids movement.
Thank you very much, Katie, for that very kind introduction. Really appreciate it. I'd like to acknowledge that CLAN's headquartered on the lands of the Wallumattagal people of the Eora Nation, and pay my respects to elders past and present. Next slide, thanks, Katie. Just as a background, this event is focused on small island developing states, which is really exciting. We had a World Health Assembly event here in Geneva, where I'm based currently, and had a great chance to talk about newborn screening more generally, but it's very exciting to focus on small island developing states here today. As a background, though, I wanted to give a very brief introduction to Mates for Kids. And Mates for Kids came about after we learned about really difficult situations for children living with congenital adrenal hyperplasia in Africa, having worked with many stakeholders in the Asia Pacific region for some time, and seeing that you could have some really great advances and changes for children when you had really strong multi-sectoral action. So we decided to be very bold and set ourselves a goal of reducing the preventable mortality associated with CAH by 30% by 2030. And we believe that by focusing on this, we're contributing to efforts to achieve the SDGs, as Katie mentioned earlier, particularly 3.2.1, 3.2.2 and 3.4. And we prepared a briefing paper for WHO, and we identified that there were really 3 key objectives that we needed to focus on. Next slide. Thanks, Katie. To reduce mortality associated with CAH, we're going to have to focus on really bold action between now and 2030. As I mentioned, we've seen a lot of change since we started in 2004, and this is the timeline here, and you can see where we heard from Zimbabwe in 2021, and that's where we decided that we'd really have to do some bold action between now and 2030. Thanks, Katie. The 3 things that we felt that we would need to focus on are access to medicines, strengthening CAH communities, and scaling newborn screening, which is really where the Mates for Kids network has really drawn on some of the champions in the newborn screening space, such as the International Society of Neonatal Screening. And we're really thankful for the expertise that so many of the Mates for Kids are bringing to the work that we're doing. We focus on having the CAH community, families, children at the centre. We try and work with as many different stakeholders as we can. And every quarter we hold community of practice meetings. With the time zones, we have to split things up. So one quarter we'll work with the Americas, Africa and Europe. The next quarter we'll work with the Western Pacific region, Southeast Asian region and the Eastern Mediterranean region. And we will hold events, community of practice meetings, and really share successes across those 3 objectives that we have together. Thanks, Katie. We are, as part of the work of scaling newborn screening, really trying to be clear on what is it that we're talking about when we're talking about newborn screening. For instance, we're not just talking about blood spot screening necessarily, although today we will be focusing a lot on blood spot screening, but we also acknowledge that comprehensive newborn screening programs include physical examination of a baby, or hearing tests, or vision tests, or pulse oximetry. But we're also talking about all of the different, the 6 building blocks that need to be addressed, the really holistic approach that we need to have if we're going to scale newborn screening, who needs to be involved, the principles that might inform our actions together, acknowledging the different challenges and barriers, but also celebrating successes as well. So we've been working on a consensus statement. We socialised it at the World Health Assembly, and Katie will be including a link to this in the chat today. We welcome you all to have a look at it, and by all means, please let us know any feedback that you would like us to include, so that we're really all on the same page, all talking the same talk. We all know what we're all talking about. It's been fantastic being here in Geneva and meeting people who are working in, say, the clubfoot or sickle cell disease, a broad range of groups who are really passionate about newborn screening as well. Thanks, Katie. The only other thing that I wanted to speak about were some grants that we've been launching to support community development activities around newborn screening, but also strengthening CAH communities. And these grants are just very small grants, but they are being implemented over a 1-year period, and they're being given to lower income countries. But I'll talk more about the grants, I think, at the end, Katie, and I'll just let you go back now, if that's okay, Katie. I feel like that's probably enough on that. We've given grants to Colombia, for example. Siendo Foundation has started a CAH community in Colombia. They actually already have newborn screening for CAH, but this was the first time that many families living with CAH had the chance to meet together. The next grant, there's teams in Sri Lanka who are doing some fantastic work around community development for CAH, translating educational resources to help young people who are living with CAH, and they'll be having their first CAH club meeting later this year. There is no screening for CAH in Sri Lanka, and I know that that is a priority for them for the future. Thank you. We're now doing round 2 grants, and we were very pleased to announce these grant winners at WHA this week. Uganda, led by Dr. Esther Coble, will be leading a project on really scaling the capacity of health workers who are helping them learn more about newborn screening and prepare for newborn screening. The Minister for Health for Uganda has been talking about some really remarkable work they're doing, particularly around sickle cell newborn screening. But in the future, when there is more expanded newborn screening program, this is a little bit of pre-work that the team are doing there around raising awareness of other conditions that there can be screening for. Thanks, Katie. We'll be hearing more from the team from the Solomon Islands, so I won't say much more about that, but it's just a real honour to give a small grant towards the great work that's happening there. And that funding is just going to be used for translating some educational resources and helping support newborn screening programs. And finally, Kenya. We're very pleased to support some work there by Dr. Phoebe Wamalwa. My apologies on the pronunciation. And again, really focusing on health worker capacity building, which is exciting. So that's really it from me, I think. Thanks, Katie.
Thank you, Kate. All right, so next I'd like to introduce Dr. Carmencita Padilla. Dr. Carmencita is an Emeritus Professor at the University of the Philippines, Manila. She's a pioneer in genetics in the Philippines and Asia Pacific. She developed the country's sustainable newborn screening system and helped pass the Newborn Screening Act of 2004 and the Rare Diseases Act of 2016. Dr. Carmencita works in partnership with Dr. Bradford Therrell, who is a research professor at the University of Texas San Antonio Health Center and is an international newborn screening consultant.
Thank you, Katie. Can I have my slides now? Okay, good morning, good evening, good afternoon. This is a summary of data from the SIDS and how it compares globally in a shared paper by both Dr. Therrell and myself. The outline of my talk will be, next slide, please. I'm going to provide some information about international newborn screening, information collection. We'll have a brief review of the latest published report on newborn screening activities worldwide, and then discuss available information on newborn screening in the 39 small island developing states and the 18 associate members. Next slide, please. There are some papers that are worth being shared with the group. This really started in 2007 when, after a conference, we came up with 5 papers separately in North America, for Europe, Asia Pacific, the Middle East, and the Latin America. But the subsequent paper in 2015, next slide, please, talks about the whole world in one paper. So this time, having all of the countries in one paper gives us a perspective on how we compare with the rest of the world. And this one actually has tables that may be useful for the audience. Now, this 2015 paper has been updated. And the next slide is a paper that just came out actually last week. So this is it's actually an updated version of the 2015 paper. And this cuts across the whole world now. And it's a very long paper. It's 184 pages with 1,600 references across the whole paper. So which means if you wanted to know what's happening with a particular country in any part of the world, so long as there is information available, then it will be in this paper. Next slide. So how was this paper written up? So just like the 2015 paper, the world was divided again into the North America, Latin America, and the Caribbean, Europe, Middle East, and North Africa, Asia Pacific, and Asia Pacific. And next slide. And people were assigned actually to reach out to the people within the region. So for instance, in my case, I tried to reach out to all the known, or maybe the people I was not familiar with, in terms of as a possible contact for newborn screening. And a certain format for the table was given such that we are able to compare the performance of a specific country in comparison with the world. Next slide, please. So this is the process of the data collection. We got the data regionally. We checked all the possible websites, all the existing publications. We reached out to all our personal contacts, and we looked at regional, national, and local discussions in newborn screening in the past few years. And it's difficult when it's not published because we have to reach out to the person and find out if there's a reference that could be used. And then finally, there will be a summary table showing the demographics and the newborn screening activities. Next slide, please. Now, the next few slides will show some example tables for regions where there are SIDS activities. And I will walk you through the table, and there will be arrows on the side which will point to the SIDS country. So in other words, in these tables, some of your countries have been integrated already. In the tables, we do have some information in some of the SIDS, but not all SIDS were covered in the global data collection, and that's why this exercise is very important. Now, towards the end of my talk, I will summarize all the SIDS tables in a page so that we can actually compare the performance of these countries. Next slide, please. So let's start with the Latin America and the Caribbean. Now, all the arrows on the left side point to one of the countries in your SIDS. And you can see, and just allow me to walk you through this first slide first. On the top will be some information on, there will be some information on some demographics. And if you can see the colored green, yellow, and the peach, blue, and light yellow would actually refer to a set of conditions that have been used. We tried to come up with a panel of conditions that was actually common across the world. And that way we're able to compare performance, coverage in terms of coverage in the population. Now, the countries, there are actually, there's a legend. When you have a full circle, it means you're screening more than 50%, and there is a mandate for the population screening. If it's an open circle, then that means that less than 50% have been covered. And if you have a cross, it means that it's in limited areas. I encourage you to take a look at the paper because it's interesting to see across the world. So for today's presentation, what is important is actually where the white arrow is. And as you can see that there's really very little newborn screening because we see very few dots, full dots in the countries that are part of SIDS. Next slide, please. Now, especially in sub-Saharan Africa, you can see that there's really very little information that we can see. And there's, in other words, there's a lot of work to be done. And the next slide, from North America, you can see now the arrows at the bottom. For the ones that are connected with the US, we have a lot of full circle. So this means that some of the members of SIDS actually have full circles. That means there has been screening more than 50%, or there's a mandate for full screening across the country. And you know, and this has been happening for a while. So this information is up to 2023, and you can see that some of your countries in SIDS are actually doing well because they have already a full screening in their respective countries. Next slide. In the Asia Pacific, you actually included Singapore, and you can see that Singapore actually has full screening. And as a matter of fact, they're covering so many conditions. They have gone all the way to expanded screening. So we can see now that in some parts of the world, even if they are part of your part of SIDS, you can see that they have been able to achieve a level of performance that's comparable to the other countries. So it's really, you can see the variation in the information that that's available to us. But for Papua New Guinea, we have really no information for that country. Now, the next slide actually tries to put together all the countries with the white arrows. So if you can see now, if you get all the countries I've actually put in the previous slides and put them in one page, this is what we're getting. The upper part of the graph of this table actually refers to the small islands and developing states. And the one at the bottom are actually associate members. And you can see that just looking at this table, there are very few full dots for the SIDS membership. For the associate members, we do have more with full circles, which means they have been able to put actually newborn screening already in the agenda, health agenda of the country. Now, The next slide will just make this a little bigger. This is really just to see how you, together. But then this slide will show you just to make it a little bit bigger, data from the small island and developing states, and just to see that the exercise of reaching out to the islands is really very critical, because we know exactly where there's very little work that's happening, or really there's no information we're able to get. You have to understand that this information was taken from publications, personal contacts. It's possible that this will change with time, but attention must be given to the small islands and developing states, because, in other words, there's work to be done. So for this group, we can already identify which countries we have to go into, and a lot of them actually are in Africa. The next slide is going to be for the associate members. And I think this is interesting, because as you can see that a great number of these associate members have full circles. And for all of the countries with full circles, they've had these full circles already for quite some time. And this only means that they have been able to integrate it into the health agenda of the country. And for all the countries that we have been able to review, the financing for newborn screening has been resolved, either covered by the government or by insurance. If you go to the 2015 paper, I think that's 2015 paper, it talks also about who's funding the program. And as we all know, getting to the agenda of the health ministry is so crucial to be able to reach that point of having a full circle. So next slide. I'm just about to. So what have we gathered from this exercise? Well, the majority of the SIDS reside in the Caribbean and Africa. And when we reviewed these countries, and as well as where they rank in the world, on the average, the SIDS are among the poorest countries in the world, 22 of the top 100. The predominant condition amenable to NBS is sickle cell disease in most SIDS. And most of the countries from which little or no NBS information was obtained were actually SIDS. And really, this is one of the upcoming side papers. So let me share with you that when we reviewed the data across the world, we've been able to come up with pockets of information that can be pulled out and evaluated, so that we can have better recommendation to the country or to the region. These are information that's, as I said, open to the public, and I'm really happy that we've been able to have this chance to be part of this group, and happy to be, to participate in any form of conversation with regards to newborn screening at SIDS and associate members. I think that's the end, and thank you very much again for the opportunity for sharing this information. Thank you very much. I think that's the last, right, Katie?
Mhm.
That's right. Okay. Thank you.
Okay,
Thank you
great.
very much.
Thank you so much, Dr. Carmencita. Our next speaker is Professor Paul Hoffman, a pediatric endocrinologist and researcher based at the Liggins Institute at the University of Auckland. His interests include developmental origins of adult health and disease, pediatric outcomes from assisted reproductive technologies, and newborn screening for congenital adrenal hyperplasia and hypothyroidism.
Right, thanks, Katie. Could I have the first slide, please? It's an absolute pleasure to be here today speaking to you all about a subject that I'm very passionate about, and that is newborn screening and getting it started in the Pacific. And I wish I could say that I had great news and everybody was starting newborn screening, but unfortunately, as many of you know, this is a long, protracted problem, and we're getting there, but we have not yet started in any of the countries to date, although Vanuatu is looking promising, and it has started in America and Samoa, I understand, and of course it's a present in Hawaii and other American states. Could I have the next slide, please, Katie? just as a revision of what we're looking at here, and Carmencita really nicely set the scene here. In the Pacific, sickle cell is less of an issue, but there are a number of other conditions which we need to think about. But when we're thinking about newborn screening conditions, we need to be looking at a condition where you have a treatment that's available, that's cheap, and that works. And I think these are really important components, and it's something that CLAN has helped with, particularly with congenital adrenal hyperplasia, and making sure that you have access to the appropriate treatments. You need to have disorders that are sufficiently frequent to justify the costs of screening. And I'll come back to those in a second. You need an effective and, again, cheap test to test them. And you need a disorder that is likely going to lead to significant morbidity or mortality if not diagnosed and treated early. So these are the things to think about when we're looking at what we should screen for newborn screening, particularly in countries where they don't have it and you're looking at starting with one or two particular diseases. Katie, could you go to the next slide? Thanks. Great. So, okay. So what do we require to establish and expand screening programs? Well, you first of all need local advocates, and that generally requires both a pediatrician or someone, a medical person who is keen and eager and committed to the process, and they really do need to be committed. But you also need input from the government, from the health departments. You need financial commitments from the regions, from the hospital, from the country, or it can be external, such as from CLAN or the World Health Organization, among other sources. And indeed, there are sources, for instance, in New Zealand to help out with this sort of approach in the Pacific. You need infrastructure, and this is really important. It's okay getting your blood test. You need to get blood testings, but once you've got your positive result, you need to have the capacity to identify those families and then get follow-up and repeat testing as required and treatment. And that can be, or has been in the past, a problem. Less so now with the wide use of cell phones. Getting access to these families who disappear into the bush has not been as hard in more recent times. And you also need expertise available when referred patients can be assessed and treatment can be expedited. Could I have the next slide? Thanks, Katie. So if we look at those issues in a bit more detail, the biggest problem I've had to date is with getting local advocacy. And I think this is what we really need to focus on. Pediatricians, not an issue. I've got a number of pediatricians in Fiji who are desperately keen to get newborn screening started, as in Tonga. But getting their local health departments has been a real problem, at least for me. And I thought I'd cracked it last year. I had a person who was very positive, but unfortunately that has faded away and I have not been able to contact them. So the getting that local advocacy, I think, is critical. We do have money available, both from external sources, such as I say, WHO and CLAN, and also from other governments, such as New Zealand. But this is not huge costs, and this can be funded at least in part locally. And of course, you need some ongoing funding too. The infrastructure is at least partly in place in at least Fiji, and I believe in Tonga as well. And we do have expertise. I am available 24 hours a day for patients in Fiji, and I'm happy to do that for other countries. If there are patients who get identified and treatment needed, and I'm sure that Shuba and others can do this for endocrine conditions, and there are metabolic specialists who can do it for the metabolic abnormalities. Katie, please go on to the next one. So, newborn screening when you don't have much in the way of resource, and certainly there's no textbook or guide to help with this. In the Pacific, really, as Carmencita was saying, we really only have it in countries which are reasonably wealthy, which is Australia, New Zealand, Hawaii, American Samoa, not Samoa, but American Samoa is about to start newborn screening as well. And of course, we've got the Solomon Islands, which is looking really promising, and I hope starts. And as I mentioned, I have been for the last decade trying to get newborn screening started in Fiji. We have actually set up a system where that we give them our newborn screening cards And they tend to use them not for newborn screening, but when they have an unwell child, and they'll send a sample to us some weeks or months after birth for screening back in New Zealand, and they get posted back to us at variable time points. But that has actually at least started the process, and the pediatricians over there are aware and value the input that the newborn screening service does provide in New Zealand, even if they're not using those newborn screening cards as a newborn screening service currently. Katie, next slide. Now, what conditions should we start with? And I'm sure others will talk about this too. What struck me, particularly in Fiji, where I've done most of my outreach clinics, is the number of children who have had untreated hypothyroidism and are cretins with severe developmental delay, all of which are unnecessary and easily treated with very cheap therapy. This is arguably the commonest newborn condition, around 1 in 1,000 to 1 in 2,000 people, depending on the population you're looking at. And it is and the intellectual retardation is entirely preventable. So I think this is something we should really focus on. It's also a very cheap and simple test to do. The other condition is congenital adrenal hyperplasia, and I have been struck by how common this is in Fiji and in Tonga. I get more calls for patients with this condition than with congenital hypothyroidism. So my suspicion is that we are looking at a prevalence which is probably similar to that of hypothyroidism, but as I say, we don't have the data to definitely define that at the moment. The treatment's also generally cheap. There has been difficulties accessing the medications, and CLAN has really helped with that in many countries. And as importantly, with congenital adrenal hyperplasia, management can be guided by ongoing newborn screening cards after birth. We generally do them every 3 to 4 months, and we're looking at the 17-hydroxyprogesterone levels. 6 hourly over a day, they can be mailed to New Zealand. We can look at those levels, and then we can guide the local pediatricians in terms of hydrocortisone dosing. And of course, for both of these, we have expert assistance available, which I think is very helpful. So next slide. There are other uses for newborn screening as well. In particular, as I mentioned, if you've got rare-born errors in metabolism, you may not diagnose them at birth, but when the children get unwell, these cards can be sent to a newborn screening lab, and that's what happens in Fiji currently. There's clearly a delay, and there's probably morbidity and mortality associated with that, but nevertheless, they can make a diagnosis faster than they otherwise would. There's, as I mentioned also, there's an issue for ongoing follow-up, especially for CAH. So you can actually use these cards to look at looking at 17-hydroxyprogesterone levels, but you could also potentially use the cards for TSH levels if you couldn't do thyroid function tests. So there is capacity to use the cards to monitor treatment in countries where it is difficult to access the blood tests themselves. Thank you, Katie. Next slide. So in summary, we still have a long way to go to get comprehensive newborn screening throughout the Pacific, but I think we're getting really close to getting it started, at least started in a number of the Pacific states. We need to identify, the critical thing for me is we need to identify the relevant health officials who can actually help drive this process locally. There are pediatricians in all the Pacific countries who are very keen to be part of this process, and it's up to us to try and help with that. The ones that I've been identifying in Fiji, Samoa, and Tonga, because those are the ones that I visit. It's vital that we support the local health professionals in establishing newborn screening. And as I said, identifying these conditions early can be life-changing, and I think it behoves us to do this. I'd like to finish there. Thank you very much for listening to me, and thank you, Katie.
Thank you so much, Professor Paul. Next, I'd like to introduce Professor Shubha Srinivasan. Professor Shuba is a pediatric endocrinologist and co-head of department at the Institute of Endocrinology and Diabetes at the Children's Hospital at Westmead in Sydney, Australia. She works closely with the New South Wales Newborn Blood Spot Screening Program and was the pediatric endocrinology representative working on the group that introduced congenital adrenal hyperplasia screening in Australia. Professor Shuba will be joined by Dr. Titus Nasi, who is the head of pediatrics at National Referral Hospital in Honiara in the Solomon Islands.
So thank you, Katie, for that introduction. I might actually ask Dr. Titus Nasi to start to set the scene about this project before I go on with my slides.
Thank you, Dr. Shuba and Katie, and thank you, everyone. I acknowledge the traditional land owners, and thank you for inviting us, Solomon Islands and the clan to do this for us. So this, I think the discussion went back 2020 during the COVID sessions when we started having TPA, taking pediatrics aboard sessions with through Prof. Catherine and then Dr. Shuba, and the discussion was that we have cases of hypothyroidism that usually come in late to us from the provinces. And just a bit of background: Solomon Islands consist of a number of provinces, 9 provinces, population about 720,000. And it's scattered over 2 million square kilometers of water. And sorry, I've just got cut off there. So it's a lot of logistics to get the newborn through. So I said this with the session we had with Dr. Shuba, and then the discussion was to try and set up something to do with the newborn screening. We don't have newborn screening in the country. The lab services is very minimal in terms of support. First question Dr. Shuba asked me was, would we get the cards sent over? And I asked the lab guys, and they don't know how to make it possible. So, and then we start discussing about this. And now flights, they only send specimen to Brisbane, Queensland reference lab for testing once a week, which is still the case, usually funded by DFAC and then the government, and there's difficulty in terms of funding. So those are some of the issues we were discussing, and then this came about in terms of setting up a screening pilot study, and then working with the New South Wales newborn screening, and then set with client, and now we're discussing this to try and set it up with the Ministry of Health on board and the National Referral Hospital Executive on board. So I think all of us are looking forward to that. Thank you.
Thank you, Dr. Titus. I'll just go through briefly about the proposed project that we're working on. And this is very much a collaboration with the National Referral Hospital in Honiara, with Dr. Titus and his colleagues. I'll go through that. New South Wales Newborn Blood Spot Screening, Taking Pediatrics Abroad, which is the charity that I volunteer with, CLAN, as we've all heard about today, and the Sydney Children's Hospital Network. Next slide, please, Katie. So far, and as Dr. Paul Hoffman has said, we've got buy-in from all the clinicians. I think we all understand the real importance and the need for this. So in terms of paediatricians and newborn screening, so from the medical superintendent, Dr. Titus is head of Department of Paediatrics, the head of neonatology, Dr. Carol, Dr. Leanne from obstetrics and gynecology, Sister Susan from the head of midwifery, and I'll talk about the importance of them in our project, and a real champion, Dr. Zarina who is a paediatric registrar who is going to take this on as a project once we get started. And in Australia, we have Dr. Catherine Currow from TPA, myself, Kate with her Mates for Kids and Clan work, and Dr. Enzo Ranieri and Dr. Tiffany Wooten, who are from newborn screening. And I've also been in discussion with colleagues in New Zealand, Diane Webster and Natasha Heather, about this project. I've been in discussion with, in partnership with Revity to work with how we can access reagents, and also DHL from a couriering point of view. So we're trying to look at it from a holistic project point of view. And the local team, as well as with TPA, we're going to be working with the Ministry of Health in Honiara, because as Paul has already mentioned, I think that's one of the rate limiting steps is getting the ministries on board. Next slide, please, Katie. So we've got our team. I'm not going to go through too much about congenital hypothyroidism. I think this group knows about that. But as you know, we've been screening for congenital hypothyroidism for over 50 years in many countries worldwide. And untreated, it can lead to severe permanent cognitive disability and stunted growth. And these are the patients that Dr. Titus and his team have been referring to me through TPA. They are probably seeing about 5 or 6 children per year presenting with a delayed diagnosis of untreated congenital hypothyroidism. And so we really want to, detect these babies at birth and start treatment. Thyroxine treatment is available in the Solomons, and it is cheap. So we can prevent these outcomes. Next slide, please. So most countries with established newborn screening programs use capillary TSH screening on heel prick tests at 48 to 72 hours. But a number of countries do have difficulties with recalling babies at day 2 to 3 and due to early discharge after delivery. And so there's been some data coming out from India, Saudi Arabia, Nigeria, Malaysia, using cord blood TSH. So we thought we'd explore this as an option in Honiara to see whether that could help with a higher uptake of newborn blood spot screening. Next slide, please. So what we're planning is a 3-year pilot program just in Honiara with a view to expanding to the rest of the Solomon Islands once feasibility is established. And we thought that by establishing a process of the screening, getting the cards initially sent to New South Wales newborn screening, we obviously, the cord blood is a little bit of an unknown for us because that's not something that we do in New South Wales newborn screening, but we have data from other countries, and then basically help build the local capacity in Honiara for a process for newborn screening. And this could then potentially move to heel prick capillary testing so that other conditions could be added on if they're not appropriate for cord blood. These are the things that we'd like to explore after this project is set up. And using the clan approach and the Mates for Kids approach of a rights-based health system to strengthen community development approach to optimising health outcomes for children in the Solomon Islands. Next slide, please. So where are we at? We're in the process of developing a protocol and with each of the roles of the various stakeholders. So we're looking to facilitate government and hospital support at NRH. Through TPA is looking at the financial support for reagents and couriering of samples to come to New South Wales initially. But then to ultimately build up capacity for the screening to be done locally. We thought by providing pilot data that would help to advocate with the ministry in the Solomons. Empowering and supervising the midwives, the paediatric registrars to collect the data that's needed, the contact details, notification of results. As Paul has already mentioned, he's available 24/7, and that's my intention as well, is to be able to be the conduit for those results and to provide advice whenever needed. And then to ensure that thyroxine is started within 2 to 4 weeks of life to maximise outcomes. So part of the protocol is having the plan for treatment and monitoring, which a lot of us take for granted in the countries where we work, but helping the local team to build that up. Next slide, please. So just coming basically to finish up, that basically what we're looking at is to really, through TPA, NRH and the New South Wales Newborn Screening program, to really partner up with our colleagues in the Solomon Islands to have a person, family and community-centred approach using the 6 pillars that Kate has already mentioned, from Clan and Mates for Kids. So I'll stop at that, and thank you for listening.
Thank you very much, Dr. Titus and Professor Shuba. Next, I'd like to introduce Sir Colin Tukutonga. Sir Colin is a Niuean public health medicine specialist. He's currently Associate Dean Pacific at the University of Auckland Faculty of Medical and Health Sciences, co-director of the University of Auckland Research Centre for Pacific and Global Health, and Associate Professor of Public Health. Sir Colin is a career public servant with extensive experience in New Zealand, the Pacific, and internationally.
Thank you, Kate. If you could, good morning or good afternoon, wherever you are. I have a few slides. I was asked to speak briefly about the challenges and barriers for screening. Next slide, please. I don't want to bore you telling you stuff that you already know. So the two big issues in the region, one is money, and the other is people to do the work. In other words, I don't think there's a real need to go over the benefits of screening. It's about how do we enable this to happen across the region. Niue and the Cook Islands, and to some extent Tokelau, for example, have the benefit of their association with New Zealand, but the newborn screening is not available consistently across the region. So I have a suggestion for you. Next slide, please. As I say, background you already know. Unfortunately, the population concentrations, Papua New Guinea, Solomons, Vanuatu, have more challenges with service delivery, and the smaller places, I made mention of the Cooks and Niue, for example, generally have better support, particularly from New Zealand. Next slide. So, as I say, there are two issues that I want to highlight. One is, how do we navigate to get a program like newborn screening accepted and funded and supported by all of the island nations? This is a list of all the barriers, I'm sure, that are familiar to you. And it's really very difficult to continue to push ministers of health at the local level to introduce yet another program, because they don't actually have much in the way of resources, financial resources particularly. So we all have this bad habit of descending on these folks saying, you should do this, you should do that. But, you know, I wouldn't want to be the health minister in Nauru. So that's a very real issue. The second, of course, related to that is the people to do the work. So I want to talk a little bit about the bigger challenges, if you like. Next slide, thanks. This is a slide of the maternity unit in Betio and Kiribati. Fortunately, I think DFAT is helping them to relocate the facilities somewhere safer. But climate change is a big issue in the islands, threatening lives, livelihoods, healthcare facilities, adding significant additional cost, both human and financial cost to families, to communities, and of course, health services. Next slide. The climate crisis has pretty much affects all of the determinants that we know about in terms of health and healthcare, particularly the low-lying atolls in the north. But severe weather events and ocean acidification, of course, affects pretty much all of the island nations. So this is a very real challenge for them all. Next. I'll just skip this. Go to the next slide, please. So here's an important slide. Most say that you need to allocate at least 5% of GDP to at least get basic healthcare available to your people. And if you look at the island nations, many of them spend less than 5% on healthcare. It's a miracle that Fiji, for example, that hovers around just below 5%, are able to deliver vaccination and healthcare for quite a small allocation. And there's the same issue elsewhere in the region, Papua New Guinea, particularly acute. So the availability of money is a real challenge. And as I said at the beginning, we need to be creative about how we support these new developments, because it's very difficult for the local folk to allocate additional money to new programs or additional programs or different programs from just within their own resources. Next slide. Talked already about this chronic shortage of key people in the health sector. Migration obviously is a big one. It's also important to point out that part of the problem is not is that there just aren't enough people being trained. Again, a reflection of the resource constraints. And when we're talking about a new program, we need to be aware about how do we support the island nations to have the people, the right people, offering the care that's needed. Next slide. So there are obviously significant challenges in the region. Newborn screening, as I say, the benefits are pretty clear, at least in my view. But it's how do we encourage, enable, and support all of the islands to offer this service? It's clearly really important for for newborn. There is here's a suggestion. There is a annual heads of health meeting. These are the permanent heads of health services across the region. They meet annually, usually in Fiji, where they debate, discuss new ideas, new proposals, changes that might be needed. And the idea is that those the conclusions from those meetings are then presented to the ministers of health, the WHO SPC Ministers of Health meeting, which takes place every 2 years. The next one is in Samoa in 2025. And why is this important? It's important because if you get ministerial level commitment to introducing a new idea, you usually get not only the political support, but the resources that are needed for this to happen. And so my suggestion for you all, and happy to help if I'm needed, to present the proposal to the heads of health meeting through SBC and WHO, and hopefully get it signed off by the ministers. That way you get political support, the necessary resources, but it's also a regional thing. So you won't have this ad hoc, somewhat what's the word, uncertain service. So it's introduced right across the region rather than just a few countries that are able to support it. So anyway, a short summary for you all and the suggestions as to how you might take this forward. Thank you very much.
Thank you, Sir Colin, for sharing. So our next speaker is Dr. Muhammad Faizi. He is the head commissioner of the National Newborn Screening Program in Indonesia. He's also the current chairman of the Endocrinology Working Group in the Indonesian Pediatric Society. Graduated from Universitas Airlangga, Dr. Faizi has received various fellowships and trainings in Indonesia, Singapore, and Japan. He is also currently the head of Department for Pediatrics in the Faculty of Medicine, Universitas Airlangga.
Thank you, Kathy. Good morning and good afternoon. Greeting from Indonesia. First of all, I want to thank for the opportunity to share our experiences related to the implementation of newborn screening in our country, Indonesia. Slide. The history of NPS in Indonesia starting from 2000 until 2005, when our government got support from International Atomic Agency to initiate the newborn screening for congenital hyperthyroidism. We start with a pilot study in 2 hospitals. The first one in Hasan Sadikin, Bandung, and the other one in Cipto Mangunkusumo Hospital in Jakarta. Upon the completion of health technology assessment in 2006, including by Indonesian Pediatric Society, Indonesian Obstetric and Gynecology Society, and Indonesian Midwife Association, the congenital hypothyroidism newborn screening expanded to 8 provinces in 2008, including West Sumatra, Jakarta, West Java, Central Java, East Java, Yogyakarta, Bali, and South Sulawesi. And in 2014, the Ministry of Health released a decree mandating congenital hypothyroidism as NPS. Until 2013, NPS involves 11 provinces and developed 4 central laboratories in Indonesia. However, the screening coverage is still low as 2%. And in August 2022, our minister relaunching NPS program, and followed by release of national policy that makes NPS as requirement for all healthcare professionals to claim delivery payment from the national insurance in September 2023. Slide, please. The year of 2023 is a year of change. I mean, our government developed 11 laboratories to support the NPS across of Indonesia. In September 2023, 2023, the Minister of Health declares that the implementation of perinatal hypothyroidism screening program is a prerequisite for health workers to claim delivery rates. Slide, please. In the slide, show the progress report time by time coverage NPS from 2022 until 2023. In the left picture, you can see sharp increasing of screening coverage after relaunch program on August 2022. And during this period from 2022 until the end of 2023, the screening coverage increased from 2.3 until up to 65%. And at the beginning of the year 2024, the government set a target of coverage up to 90% of all newborns in Indonesia. Slide, please. Slide. Yeah, this is a example for our campaigns after relaunch NPS in August. The minister, since the launch of the program, the Minister of Health has been increasing diligent campaigns for CH NPS program to various media. NPS for healthy babies and NPS reduce the risk of disability of children. Slide. This is our publication in International Journal of Neonatal Screening 2024. From survey to 423 respondents of health care professionals, there are only 36.5% of healthcare workers have received formal prenatal hypothyroidism NPS training. Only pediatric endocrinologists receive formal training, and we just have 53 pediatric endocrinologists across Indonesia. And involving health professional organizations such as Indonesian Pediatric Society and Indonesian Clinical Pathologists Association, we have developed a guideline and NPS training curriculum. And during the last trimester 2023 until first trimester 2024, we have did a virtual training for healthcare professional, including GP, midwife, and nurses and pediatricians. More than 10,000 participants was involved to this training. Slide, please. Yeah. During last trimester 2022 until first trimester 2024, we collaborate between Indonesian Pediatric Society and Clinical Pathologists Association. We have trained more than 280 trainings involving more than 40 speakers and across 7 provinces. It's much mistyped, yeah. 7 provinces and up to 15 series in each province. Slide. Yeah, in 2024, our minister has a target to maintain and increase coverage and the capacity of laboratories from 50,000 a week to 80,000 a week. We also do a pilot project NPS for CAH, GCPD, and critical congenital heart disease and hearing loss in 5 provinces, Jakarta, West Java, Banten, Jogja, and Central Java. The conclusion, the government's support for NPS is most important thing for success a program. NPS should be a priority of government's health development policy. Slide. Thank you very much for attention. Back to Katie.
Thank you so much, Dr. Daisy. So now I'd like to reintroduce Dr. Kate Armstrong and introduce Professor Diane Webster. Diane has held a leadership role in newborn screening in New Zealand since 1986. She serves as a member of the Clinical and Laboratory Standards Expert Panel on Newborn Screening. She is the current Vice President of the International Society for Neonatal Screening. Additionally, she is an active member on the Task Force on Newborn Screening under the International Federation of Clinical Chemistry and the International Society for Neonatal Screening.
Thanks so much, Katie. And huge thanks to everyone for the brilliant talks that we've had so far. Just really excellent and really setting the scene brilliantly. So thank you very much to everyone. I'm going to ask Diane to share some of her reflections, but I'll just share the scene with you all. We were very fortunate this week on Sunday, the 26th of May, to hold a hybrid event on the sidelines of the World Health Assembly, the 77th World Health Assembly here in Geneva. We had a stellar cast of speakers, and Diane was our wonderful MC for the event. We had 3 separate panels. The first panel, we had Dr. Aisha Khan, who's on the ISNS and IFCC task force for newborn screening, and the Honourable Minister for Health from Indonesia, and Aman Palangan, a paediatric endocrinologist and colleague of Dr. Faizi, speaking about the work that they've been doing in, Dr. Aisha spoke about Pakistan, but also gave global data insights. And then the team from Indonesia shared their stories as well. The second panel, thanks, Katie, if we can just go on to the next slide. We had a focus on Africa, newborn screening in Africa, with specific focus on sickle cell disease, and really inspirational presentations from Leah, a young woman living with sickle cell disease, and also Dr. Ordame, who is a clinician, oncologist, looking after patients with sickle cell disease, but also a leader with the World Sickle Cell Disease Coalition. We also had Dr. Anshu Banerjee from WHO give an update on WHO's approach to newborn screening frameworks that they're using to support member states as they are rolling out screening. And the final panel really was about looking at tools that we might have to support newborn screening within the Mates for Kids network. We've got the consensus statement. We've shared a link to that in the chat, and also the child-friendly rights flyer. And one of our fantastic young people, Sienna, is going to speak to that next. So I won't go into that just yet. But it was a terrific opportunity for hearing a broad range of discussions. And in the third panel, perhaps the highlight was a presentation by Dr. Naveen Thakkar, the president of the International Paediatric Association. And he spoke about the key role that paediatricians can play in scaling newborn screening, and in no uncertain terms really committed to the IPA really supporting efforts to scale newborn screening moving forward. Next slide, thanks, Katie. So these were some of the general reflections that came out for us from the event. I'll just run through these, but then I'll hand to Diane, because as MC, she really brought the whole event together beautifully. Some key take-home messages were, and Dr. Schuber shared this diagram really with the 6 building blocks of the WHO. So, and focusing on children and families who get a diagnosis out of newborn screening, but the importance of community and stakeholder engagement, government governance and financing, and we really saw the importance of leadership from government that really shone through with the presentation from Indonesia in particular, the importance of access to medicines, equipment and technologies, health service delivery at all levels of a comprehensive newborn screening program, and WHO really stressed that, you know, comprehensive approach, it involves physical screening and hearing and vision and pulse oximetry, as well as blood spot screening. Then the health workforce, and really that presentation by IPA, the Pediatric Association, really was very encouraging, but there's so many different elements of the workforce. There's the laboratory staff, but there's also the midwives, the health workers. So many people need to be involved. And finally, information systems need to be part of that as well. So future opportunities, Sir Colin's words around the Heads of Health meeting is groundbreaking and exciting, and really just something that I know that we're all going to, you know, jump on. And I think he's set us afire there tonight with this. Other reflections that came out of WHA 77, the importance of us all continuing to share success stories, tools, resources and learnings. The critical importance which has come through today around political engagement and financing and high-level government support. WHO does have a strong interest in this and supporting member states in this space, and they are developing a framework at the moment. And we will be sharing a recording of the event, and Dr. Anshu Banerjee's presentation was really helpful, I think, in understanding a bit more about where WHO is coming from there. Partnerships with other childhood NCD communities really came through, and there was another side event on newborns that focused on screening, really led by Miracle Feet, Operation Smile, Children's Heart Link, a whole lot of other groups that are really sort of pushing for that physical examination of a child to be a critical part of comprehensive newborn screening programs, and early treatment for, say, clubfoot, cleft palate, congenital heart disease. The power of privileging lived experience came through with Leah speaking about her life with sickle cell disease, and really continuing to bring people who are living with these conditions that are diagnosed through newborn screening to the table. I mentioned the International Pediatric Association, leveraging the power of that organisation. And finally, ensuring sustainable and affordable access to treatment and care just really needs to be at the heart of it all. So they were some initial reflections. We will be, as I mentioned, preparing a report and sharing a link to it. But I'd like to hand over to Diane now to share her reflections on the event and other words of wisdom. Thanks, Diane.
Thank you, Kate, and thank you, Katie, very much. I guess there's really 3 key things that come for me from WHA 77. One is very encouraging listening to Dr. Anshu Banerjee talking about the World Health Organization and how they are nudging their main goals, which have been mortality and birth defects, towards language which is going to include newborn screening. Because I think you mostly realize that reducing mortality is a great goal, but newborn screening isn't going to contribute very much to that. And it's very good to hear him talking about improving the quality of life as well, bringing that in with, or bringing morbidity in with mortality there. And secondarily, their focus on birth defects has been primarily on physical defects. And it's very encouraging to hear them beginning to include biochemical and other birth defects in there, that things that are not so obviously physical. So looking forward to seeing how they go with developing the framework and resources that they're planning for newborn screening in developing programs. My second bit of inspiration comes from Indonesia. And I'm not sure that everybody who is listening today understands the magnitude of the achievement in Indonesia. This is an archipelago of many, many little islands, but in a country that has 4.6 million births a year. And very inspiring listening to their Minister of Health talking about the work that he has been doing with Dr. Faizi and Dr. Aman Polangam to scale up newborn screening. A key point was that as Minister of Health, somebody with no health experience when he came into the role, very quickly realized that prevention is key to getting good value for money out of spent health dollars. And by linking newborn screening to other payments for healthcare, he has been astonishingly successful, as Dr. Faizi has been telling you, in scaling up newborn screening in Indonesia. It's so inspiring to hear what has been able to be done with that link to money and that political will. And so while absolutely I agree that people like pediatricians are key and really important to be involved in newborn screening at all steps of the screening pathway, without that political involvement and political will, it's very, very difficult to make progress. And the third thing I would say is how very important advocacy from patient groups and people with lived experience of the screened diseases can be to advocating for newborn screening. And Leah was particularly eloquent talking about her experiences of living with sickle cell. So thank you all very much. It was a really great meeting, really inspirational.
Thank you, Diane. And Diane is so humble, but she really was a brilliant MC. And I've had so many people coming up and saying, wow, she really knows this topic really well. And that's an understatement.
Doing it for long enough.
So back to you.
Open.
Back to you. Thanks, Katie.
All right, thank you, Kate and Diane. Oh, upcoming events, if you want to talk about that, Kate.
Yeah, look, thank you. We're all going to be happy to have a well-earned rest after today's event, and thanks everyone. And Diane's been involved in both events, but we do have, I'll swap these around, International Neonatal Screening Day is coming up on the 28th of June. This is an opportunity for us all to just really continue working together, advocating, raising awareness. We will be officially launching the consensus statement and our child-friendly rights flyer, which Sienna will be speaking about next on the 28th of June. And we will be sharing those with you and making sure your input's in it and that it reflects as many different organisations and voices as possible. So please get involved and support that. And then there's a UN Science Summit. We have only just found out that we were accepted for that. That's in September. We're yet to find out the date. But we will be in touch and welcome people to be involved and hope that that's another opportunity where we can continue to drive momentum and continue the conversation. Thanks, Katie.
No problem. All right, so now I'd like to introduce Sienna Gates. Sienna is a project support youth advisor for CLAN studying pre-medicine at the University of Wollongong in Australia. She has been supporting CLAN since 2021.
Thank you so much, Katie. Yes, my name is Sienna Gates. I'm a youth advisor for Clan, as Katie said. I'm here to talk to you guys today about the newborn screening child-friendly rights flyer, which we are really, really excited to launch. For those who may not know, Clan develops child-friendly rights flyers to advocate for the rights to health and life for children and families living with chronic conditions globally. So these flyers aim to express important rights as outlined in the United Nations Convention to the Rights of the Child, and engage international communities in the effort of upholding these rights. Clan flyers are designed to be child-friendly and accessible to children and families, and to empower them with the knowledge of their rights. Clan has developed flyers for CAH, osteogenesis imperfecta, epilepsy, diabetes, and more. And many of them are available in multiple languages on our website. Next slide. Thank you, Katie. Yeah, perfect. Thank you so much. The newborn screening rights flyer expresses every child's right to access early screening and treatment that can prevent disability and death when done early. So only 30% of the 40 million babies born around the world each year receive some screening, which is simply not acceptable. On the screen, you can see some snapshots of the flyer, which show some components of a strong newborn screening program, as well as some of the rights of the child. So we were originally planning on launching the newborn screening flyer today in line with SIDS4. However, as Kate mentioned, the amazing socialization process that has happened at WHA 77 has allowed us to learn so much about the work that's going on in this space. And we want to make some improvements that will make the flyer as accessible and accurate and useful for as many groups as we possibly can. So we were able to learn more about the work of the WHO in this space, as well as connect with other civil society organizations, particularly around Clubfoot, Cleft Palate, CHD, as Kate mentioned again, and advocating for non-biomedical approaches to screening as well as biomedical ones. So well baby checks that are free and accessible and effective for all communities. We have this invaluable opportunity to continue to learn from others and connect and collaborate so that we are able to ensure the flyer can empower as many communities, families, and children as possible. So we will now aim to launch the newborn screening rights flyer alongside the consensus statement for scaling universal access to newborn screening on the 28th of June for International Neonatal Screening Day. Thank you so much.
Thank you so much, Sienna. Oh, there we go. So we look forward to sharing the Child Rights Flyer with children around the world soon. So I'd like to now transition back to Diane for our closing discussion and a Q&A.
Thank you, Katie. And should we start with Q&A? And you're going to moderate that, aren't you?
Sure, I can moderate it. We currently don't have any questions in the Zoom chat, but if anyone, you could either unmute yourself, or if you don't feel like speaking, you could comment in the chat, and we'd be more than happy to go through the questions.
We'd also like any comments that anybody has to say. And I would, first of all, like to start by thanking Kamatsita Padilla and Brad Therrell for the amazing amount of work that's in what is the absolutely biggest scientific paper I've ever seen, 198 pages. Wonderful. Well done, guys. It's going to be a really great resource for people who want to know about the state of newborn screening worldwide.
You're part of it, Diane. You know that.
I guess if I've got one message, one single strong message, is it takes us all. And that means it takes us all within a community. It takes our policymakers, it takes our funders, our pediatricians, our lab people, our follow-up, our nurses, our treating physicians, to make sure that our children, for example, with hypothyroidism, grow up tall and smart. But on a higher scale, it takes us all from different countries and different experiences to be working together to support each other as we move forward with screening.
Kate? Can I say something? Yes, because I think you know, working on this paper has made us realize that we have to encourage everybody to write their experiences, no matter how small, how big, because they will be used by other countries as models, as examples. And if we do not share it in a public forum, then the others will not know how you did it. So I just want to thank, you know, the hundreds of people who actually contributed to the paper. And this could not have happened without the support of everybody across the world.
Could I just say on that topic that many people are shy of starting to write, and sometimes because they're not confident with English language, and sometimes because they might not be very experienced in writing papers for publication. I'm a editor of the International Journal of Neonatal Screening, and we are very happy to support people in writing papers. So get in touch with me or through IJNS website if you would like to talk about that in your own situation.
Shuba, would you like
Professor Shuba.
Thanks. I think my question is what you just put in the chat, actually, Kate, is really how can we really continue to work I mean, it's just been amazing to be part of this forum today. And certainly, you know, a number of us have contacts just within our work, but I think we are also a group of committed individuals here, and it's actually getting the message out to those who don't know, and especially with policymakers and those in government, and as Colin has spoken about today. So just, yeah, trying to think what is the best way forward to really help the region with you know, the Pacific Islands. We've obviously got buy-in from clinicians, but it's getting the political will. I'd be keen for thoughts of how we can do that together.
Something that I could suggest is the World Health meeting is going to be online, and the talks will be available. And I'd be sending the Minister of Health for Indonesia's talk out to every other Minister of Health in the whole world and say, listen to this.
Great idea. Thank you, Di.
It was so different from what you might have expected from a Minister of Health. And he has clearly been so successful that he should be listened to.
Fantastic.
There's another question in the chat there, Diane. SIDS is a wide area. How do we prioritise areas initially for targeted action?
The ISNS-IFCC task force that you've briefly mentioned was set up to support countries with newborn screening with a multidisciplinary group. And we have thought that the way to prioritize is to look at where the support is already in the country. So ideally where there are or have been pilot programs, where there are committed healthcare professionals, particularly in pediatrics, and most importantly, where those people have links with their government and links with their healthcare providers. So we're looking at prioritizing where smallish efforts can bring good outcomes.
Countries with an interest in scaling newborn screening, Diane, is it appropriate for them to approach ISNS in the first instance for support?
I guess that's as good as any other place to go to be put in touch with people in the right areas, depending on where the support is required. So it has quite a good network. It doesn't have very much in the way of financial support available, although some of that's available in other ways from other sources.
Right.
But I'm absolutely happy to talk to anybody about what their next steps might be. And when we talk about scaling newborn screening, we're talking not only about increasing coverage, but we're talking about increasing the number of disorders that programs are screening for. So typically, they'll be looking at starting, depending on what continent they're in, starting with either sickle or with congenital hypothyroidism, and moving from there to adding other disorders.
Fantastic. Thank you, Diane. There's another question there. If Sir Colin could please also give us some more insights on how we could approach and prepare for a Heads of Health meeting, please.
Yeah, I've been exchanging emails. It's a relatively straightforward. I will get the item on the agenda. I will rely on you to tell us the benefits to the child, to the families, to the countries. We need to think about what the cost implications might be. If there's existing support that might ease the pressure on the poor old Minister of Health in terms of finding money, what might be essential skills to ensure that the service, I'm thinking about there's the local health workforce, but where do the tests get done? Who pays for that? Those kinds of things. These are mechanical details, if you like. It's the usual thing we do to justify a business case. But in terms of the mechanics of it, the meeting is a WHO SBC meeting. We just have to try to navigate access to putting the item on the agenda. I would have thought that at this day and age, it's totally unacceptable for babies to be permanently affected from a simple, relatively low cost intervention. I'm not an expert, so forgive me if I'm not characterizing this well enough. In other words, at the moment, we're funding things, healthcare interventions that are marginal at best, in my view, whereas children with some disorder that you could pick up relatively quickly and reliably, and an intervention or a set of interventions that potentially could benefit them. I couldn't find, to me, that's the basis of a very good justification kind of thing. Yeah, so yeah, I can only talk about the Pacific region. I realize that small island developing states, broader than that, there's the Caribbean, the Indian Ocean, but I'm only talking here about the Pacific Islands. And the benefit of a regional approach is that we try to advocate for everyone in the region. Otherwise, those with the connections and the resources and the networks will benefit, and those without will not, and we aggravate existing inequities. Sorry to go on a bit, but that's how I see it. I'm happy to help.
Fantastic.
Professor Sir Colin, I'm wondering if you could talk a little bit about how those countries prioritize their healthcare spending, and what are the levers that are able to be pulled with regard to newborn screening. So the extent to which it's reductions in morbidity and mortality, the extent to which it is cost utility, cost savings, and how does it stack up against other public health measures?
Well, firstly, it's not as sophisticated as you might expect, Diane. Most of this is a repeat of last year's budget and the year before and the year before and the year before. In other words, a lot of the resources are already spoken for. So that's why I have a lot of sympathy for the poor old Minister of Health, because he or she, in fact, doesn't have a lot of leeway and flexibility. Meanwhile, there's WHO and SPC and the professional groups are, going on at them about fund this and fund that. So it's a juggling game. And it's hard to say for certain how they do it, but it's obviously more of an art than a science. But for us, at the very least, we need to make the case for why government should fund and deliver newborn screening. And that's why I was talking about earlier about the benefits, about the estimated cost, and so on. So clearly the decision making on prioritizing in healthcare is not straightforward. But as a group, our task is to start the conversation with the benefits, the expected cost, implications for delivery, and so on and so forth. So that's how things happen normally, Diane.
It's good to know, but not awfully encouraging. Thank you so much.
Oh, I feel very
Carmen Sita.
sorry.
Yeah. I mean, for the LMICs and the LICs, it's really very challenging because you're competing for priorities. And I think what we can do for, for all of this is really to get the data out. They need to take a look at the numbers. These are the small steps. I like the story of Indonesia because they really started working on the ministry late 1990s. They have talked to all the ministers along the way since 1998. I'm aware. So you need to wait for the time when you do have somebody who's supportive. But when you have somebody supportive, you have to have the data available. So I guess, the regional approach is good because we're sort of like helping those who were not ready. But the data must be placed for each of the countries so that it can be put forth to the ministry. Unfortunately, the budget is the same, and it's a matter of how to get into the slide. So, the 2% to the 90% of Indonesia in a year is an example of political will. And, I'm really so happy for that story because I've seen them struggle from the late 1990s up to this time. So data maybe and working together will probably be something we can start with. And then the webinars that I saw on the chat group will be good, just an educational, throughout for the coming years.
Professor Shuba.
Oh, Diane.
Sorry, and probably at the risk of derailing my own project, just a question for Sir Colin. Just wondering, in terms of how the health ministers think, and I know you probably can't answer that, but is data from other countries helpful, or is providing pilot data, which what we're trying to do in the Solomons, to then advocate locally, is that more powerful by having local data of their own children, or as compared to saying, well, I mean, look at what Indonesia's done. They've been amazing. How do we? I don't know how these people think.
Yeah, I think well, money is a key thing for them. And secondly, how do I get voted back in again at the next election? Those are the things that preoccupy them, is my understanding after many years working with ministers. But two points to your question, probably a bit of both. Your local data and local circumstances are clearly more powerful. But adding in the experiences from similar countries or clearly helps. As I say, the problem with these things, it's not an exact science. It's, you know how it is. But clearly, I think in your case, you're already in Honiara. You've already got the connections and the local contacts. So that's clearly very powerful. So the short answer would be probably a bit of both local data, local experience, I think clearly preferable.
Thank you. That was our approach, was to try and do it from multiple ways, but thank you for that. Dr. Titus, I don't know if you wanted to add anything. I don't want to speak on behalf of Honiara, but that was certainly what our plan was.
No, thank you, Dr. Suba. I was thinking, asking about the same question and probably going further. Is it a possibility of submitting a combined proposal so that it's seen across the region and maybe tapping into the donor partners and saying, oh, this is a combination submission. I don't want to derail what we are doing as well. I want to start on it, but that's a thought that we could do in terms of probably if it comes under NCD. We did a rheumatic heart disease submission with Vanuatu and Fiji, and DFAC has accepted that, and they are presenting it in the side meeting in the World Health Assembly meeting today, or I think they might have presented it yesterday. And it's probably something that also we might think about. But yeah.
May I suggest too?
Sorry.
Please go ahead, Sir Colin.
Oh, Shuba, I was just going to say, I think you and your colleague Tasi in the Solomons should push ahead with your plans. The added value, the additional benefit of a heads of health / ministerial approval is it becomes a regional thing, and they then come back and report to one another at our meeting at such and such a time we agreed to do this, and a year or 2 years down the track they come back and meet again, and they're meant to report back on what they've done. That's the value of a regional a group policy approach to support whatever happens at the local level. You don't replace local ownership and local commitment with a regional promise, but they do go together. So my suggestion would be, I think you should, you're down the track, you've got your colleagues in the Solomons, I think you should push ahead. The idea of an endorsement by regional ministers, it just adds support, because otherwise, as I said earlier on, it becomes somewhat ad hoc, and some island nations will have it and some won't. So yeah, for what it's worth.
Thank you, Sir Colin.
All right, so that was a very... Oh,
sorry, Katie. I think that comes back to it takes us all, and the importance of using more than one approach, because I absolutely think that peer pressure and a regional approach is good. However, there are funding institutions who won't fund, and I'm thinking of, for example, the New Zealand MFAT, won't fund pilot projects or development without an indication of continuation of funding intention from the host country. So we need a three-way application, one from the clinical people in New Zealand, one from the clinical people in the host country, and one from the funders from the government in the host country. So on an individual basis, they're really important as well. So sorry, Katie, back to you.
oh, no worries. I see that we have a chat in the messages from Aisha that says there are many global organizations who are working for one or other aspects of NBS. However, there is a disconnect between them, and hence the efforts are not synergized. How can we bring everyone together?
I've got
If
some
anyone wants
ideas
to
about that,
comment
which
on
I'll
that.
share later.
Yeah.
We do have some ideas about how that might happen, and we'll share later. She's absolutely correct that there are many organizations, big ones like the American Public Health Association and the American Diagnostic and Laboratory Medicine and the American Society of Hematology, all of whom are working for newborn screening in or supporting various programs. And it's a question, like Aisha says, of getting everybody in the same room. There's a bit of watch this space here.
Super.
Sorry, I apologize for asking lots of questions, but I'm just really excited to have this forum. I would also just appreciate if anyone has any experience in using cord blood, because that is what our pilot project is going to do, just to help with logistics initially. And if anyone has any experience, I'd be grateful for direct contact with that.
Do you want to put your email in the chat?
I'll put my email in the chat, yes.
Shubra, as you said in your presentation, there are quite a lot of jurisdictions that have used cord blood, and I think newborn screening purists are on a tightrope, and the tightrope we're on is good public health, like screening, has to fit in with the existing healthcare system for success. And unless it does that, the infrastructure issues like collecting the sample will become difficult or impossible.
Impossible.
And if you're right, impossible. So if you're in a place where, for example, most babies are born in a facility, but length of stay is only a few hours, and then the next contact with the healthcare system is at vaccinations at 6 weeks, what do? Cord blood is good for anything that needs a gene, anything that needs a marker which is present at birth, which, for example, TSH or thyroxine are, and providing the analyzing laboratory has sophisticated enough laboratory IT to be able to make hour by hour adjustments to normal ranges. However, most countries that start off doing, for example, hypothyroidism, end up wanting to do more disorders. And for example, most of the inborn errors of metabolism are not detectable in cord blood. The markers are just not raised until the baby's been its own independent organism for a while. And countries who have started with cord blood often find it very difficult to transition to taking samples at an older age. And I think Dr. Carmen might have some comment about that as well.
Can I share a little? Okay, so
yep.
It's very challenging if you already have plans of going beyond the first disorder. And what we've experienced in Asia, and I'm talking about Hong Kong, Malaysia, and Singapore, when they wanted to move to expanding, it was extremely difficult to change the mindset from cord blood to dried blood spot. From experience, having worked with many countries, it's really hard sometimes for the logistics to start with a dried blood spot. But if you're able to show through pilots and some models that it can happen, it's really possible. So in the Philippines, we have 7,600 islands, and we collect dried blood spot. But we started really small and then expanded. So just a thought that if you consider doing cord blood, there are a lot of limitations. And changing the mindset is extremely difficult. I mean, those are my thoughts.
Really
These are
valuable
personal
insights.
thoughts.
Yeah, that's really valuable insights. Thank you very much. And I think gives us food for thought. And Dr. Titus, we can have a chat about we were originally thinking plan A with Hill Prick testing, and then saw some data on cord blood and wondered if the logistics may be easier. So that's something for us to consider. Thank you.
I think you're balancing current logistics against potential future expansion.
That's tough. Yes.
I don't know how you do it.
All right, well, thank you, everyone. That was a very productive discussion. So now I'm passing it off to Kate to close out the event.
Oh, look, thanks so much, Katie, and congratulations to you and the whole team, Sienna, Mabel, our youth team. Very grateful for your help making this event such a success. Very grateful to our speakers. We had a stellar lineup. This will be a really powerful recording. We will share a draft report with you all, with the speakers, and just check that you're happy with the representation, and then we'll be making that available along with the recording on the web page where the registration links were initially. Very excited about the future and where we go with this. It feels like there is enormous need. There's enormous hope that we're seeing from countries like Indonesia. And yeah, it just does feel like that there's this growing momentum. Mates for Kids will continue holding our quarterly meetings, and we've always had newborn screening as one of our 3 objectives, along with access to medicines, community development, and newborn screening. So we'll continue the focus on newborn screening, but we're so grateful to work with genuine experts in the field, and I really want to thank Diane for her help and guidance, and Dr. Aisha as well. But also thank you very much, Kamansita Padilla and Brad, for sharing your latest research with us all. I think that was just really timely that publication came out in time. So thank you very much. We have some more events coming up. The Science Summit, hopefully we can use that collectively to continue to advocate and drive change. And with the International Neonatal Screening Day on the 28th of June, I hope we can all work together some more. We will be in touch with the consensus statement and the flyer. But until then, just sincerest thanks to you all. Look at us finishing 2 minutes early, superstars. Very grateful to you all. It was a great meeting, and we look forward to continuing to work together. Thank you. Thank you, Katie.
Thanks, Kate and Katie. It's great.
Thank you.
Lovely.
Thank you, everyone.